Welcome to the GLP-1 RA series from the American Heart Association, sharing insights on the heart and kidney health benefits of GLP-1 receptor agonists. This series is supported by an educational grant from Novo Nordisk. CE and ABIM MOC credits available.
Welcome to Heartbeats from Lifelong Learning and our series on GLP-1 receptor agonists, What You Need to Know. Today we'll discuss the cardiovascular benefits of GLP-1 receptor agonists. This is one of a series from the American Heart Association. In this episode, you'll learn about specific cardiovascular risks while distinguishing between glycemic control and cardiovascular risk reduction. We will also highlight the benefits of treatment with GLP-1 receptor agonists in patients with diabetes. After watching this vodcast, we hope you'll be able to better recognize the increased cardiovascular risks associated with diabetes and impaired glucose tolerance, distinguish the dissociation that can exist between glycemic control and cardiovascular risk reduction with many agents used for the treatment of diabetes, and contrast with the newer agents, the GLP-1 receptor agonists and the SGLT2 inhibitors. And then identify the cardiovascular benefits of treatment with GLP-1 receptor agonists in patients with diabetes. I'm Michael Linkoff. I'm an interventional cardiologist at the Cleveland Clinic and a clinical trialist. And these are my disclosures.
Thanks, Mike. It's good to be with you today. My name is Jorge Plutsky. I'm a cardiologist. I direct preventive cardiology at the Brigham and Women's Hospital, and I'm on the faculty at Harvard Medical School, and my disclosures are shown.
All right, Jorge. So you and I are both cardiologists, but we're deeply involved both in practice and in our research in the so-called cardiometabolic field. So why are we talking about diabetes?
Yeah, it's a good and fundamental question. The fact is, we've known for a very long time that the presence of diabetes significantly increases cardiovascular risk. It's just been a very long time we've struggled with what's been referred to as the glucose paradox, that lowering glucose didn't improve cardiovascular outcomes. So on one hand, you were increasing risk. On the other hand, as you treated diabetes, you weren't decreasing that cardiovascular risk. And that's completely changed. It's really a very exciting time to be practicing because we've had the advent of two classes of medications, the SGLT2 inhibitors, and our focus today, the GLP-1 receptor agonists, that have completely upended that, with very striking demonstration of cardiovascular benefit, as we'll get into. We had initially evidence that argued that just the presence of diabetes without any other cardiovascular history conferred the same risk as someone who had a prior heart attack. We've moved away from that, but the evidence of that degree of risk equivalency, but the fact is the presence of diabetes does mean a 2 to 4-fold increase in cardiovascular adverse outcomes, whether it's heart attack, stroke, myocardial infarction, the need for coronary intervention. So the presence of diabetes is really quite a pervasive effect on the entire vasculature, increasing atherosclerosis and cardiovascular risk across the board. So I think those initial findings really are helpful for the clinician, are still in the guidelines to some extent, that when you see diabetes, you need to be thinking about cardiovascular risk, even if a patient has not yet had an event. Patients often go a long time without their diabetes even being diagnosed. We're thinking more about conditions like prediabetes and the risk associated with that. And so it's an incredibly important issue. And as I like to stress to my colleagues and our trainees, that these are cardiovascular outcomes. These are cardiovascular events. And so we have to understand the disease of diabetes and continue our understanding of the cardiovascular disease and understand therapies that improve cardiovascular outcomes, whether it's heart failure or MI, stroke, need for revascularization, cardiovascular death, and the like. And now we're into a new era of agents that actually do that. We really have to leave behind where we used to shrug our shoulders and say, yeah, but treating diabetes doesn't improve outcomes, so I'm not going to do that. I think now we have clear-cut evidence, not just of the risk of diabetes, but how we can improve outcomes by treating diabetes.
Yeah, I think we have to treat it, as you point out, just as we have to treat hypertension, and we have to treat hyperlipidemia, and we can counsel patients on smoking cessation. Diabetes becomes now one of the modifiable risk factors. Obviously the incidence of diabetes is increasing at hand in hand with the incidence or the prevalence of obesity worldwide, and so this is a growing problem. Most clinical trials show at least 40% or 50% of patients with coronary disease have diabetes, and if you count prediabetes, it looks like only about a third of patients have normal glucose regulation. So it's a huge proportion of our patients, and the vascular complications are a huge proportion of the mortality and morbidity in patients with diabetes. More than half of them die from something to do with a vascular disease, cardiovascular, cerebrovascular, or peripheral vascular. So they're so tightly linked that modifying the cardiovascular risk becomes, I won't say the most important, but certainly in terms of the serious and fatal complications, certainly one of the most important aspects.
Yes, and we've been fortunate in cardiology to have so many advances, whether it's procedures or therapies. One of the things that's certainly striking to me was that when we looked at patients with diabetes, and we looked as those advances came along, as we got into percutaneous coronary intervention and therapies, that patients with diabetes always did worse, even with the progress of those advances. And so, the need is clearly there, as people in the cardiology community may not always be seeing patients with diabetes who've not yet had an event, but the fact is we do, whether we're seeing them for arrhythmia or for consultation prior to surgery, or in other settings. But among those patients we see who've not had a prior cardiovascular event, who have diabetes, or in whom the cardiologist uncovers diabetes, which is another role we can play by checking for it. The fact is we see so many patients who have had a prior event who have diabetes, and so many of them will continue to progress even with our other therapies, that the need to treat the diabetes with agents that have cardiovascular benefits, I think is clear, and I think it helps motivate this kind of series of saying, well, let's get up to speed about what the agents are, the rationale for them, what their effects have been, how they're working, and how to use them.
Yeah, and you've mentioned the so-called diabetes paradox, but I think it warrants emphasis here. Over the last several decades, we've had a broad expansion of the number of different types of drugs that can be used to treat type 2 diabetes, oral agents, and with variable effects on actual glucose lowering, but certainly with various combinations, many or most patients can be brought to what appears to be a reasonable glucose level, or hemoglobin A1C. But their effects on cardiovascular outcomes are very different. So it's not linked just to how far you bring down the glucose and how long you bring down the glucose. Clearly, the risk it goes up with the higher levels of hemoglobin A1C, but it's not the reciprocal, as you mentioned earlier, that as you bring it down, you can count on a specific risk reduction. It does appear to be dependent upon the mechanism of the agent,
how you're doing
work.
Yeah.
So
we certainly had a lot of effort, so much effort by subjects and physicians and physician investigators, sponsors of trials trying to show whether improving glucose could improve outcomes with the older agents. And really, mostly those were unsuccessful, may have included some issues related to hypoglycemia and increasing risk, where the drugs may be increasing risk themselves. So this new era of agents that can treat diabetes and improve cardiovascular outcomes is really pointing to the idea of other mechanisms and other effects that may be quite relevant to the success that we've had with these agents and trials, and also point us to what we have to think about in terms of picking them, right patients, in order to make sure that we're taking advantage of the progress.
So we have two classes that have unequivocally been shown consistently in trials now to reduce cardiovascular events. That's aside from metformin, which I think we use or has been used as first line, but has a relatively weak body of evidence based upon subgroup analysis. But so we have the GLP-1 receptor agonists and we have the SGLT2 inhibitors. But the profile of cardiovascular risk reduction with the two has been somewhat different, suggesting that they probably have different targets. Is that your understanding as well, Jorge?
Yes. I think, when we look at the trials for the GLP-1 receptor agonists, that, first breakthrough was with liraglutide. Of course, all these agents end in that, TIDE, the tide. Any shorthands and tricks for cardiologists to get their head around these is helpful. So liraglutide in the LEADER study, which was really in response to the need to demonstrate safety, actually showed cardiovascular benefit. And that benefit really lined up with a reduction in cardiovascular events related to atherosclerotic cardiovascular disease, so MI, stroke, cardiovascular death. That evidence was quite clear cut. And then, of course, people looked at that, were, impressed, surprised. It really seemed like a breakthrough, but we like to see it again with other agents. And in fact, well, we did have follow-up trials with semaglutide that also showed benefit, and now we've had several GLP-1 receptor agonists that have shown this improvement in cardiovascular outcomes, allowing for meta-analyses to aggregate that data on cardiovascular outcomes, and it really does line up with the idea of improvement in atherosclerotic complications with ASCVD events.
Yeah,
and that signal has been quite consistent for the agents that have shown benefit.
Yes, been consistent across the agents. It's also been consistent across the endpoints. There, although cardiovascular death is always harder to show because of the number of events,
Yes.
but stroke and myocardial infarction seem to be reduced, and importantly, it seems to be in lower risk and higher risk patients. So many of these trials included a so-called primary prevention population, those that hadn't had a cardiac event but were high risk for cardiac disease, and they seem to show a similar reduction in risk. So it seems to be across the board, and as you pointed out, it seems primarily due to vascular related events. And in contrast, the SGLT2 inhibitors, which also are not the focus of this series, but certainly have revolutionized our care in cardiovascular disease, as well as heart failure and even beginning in kidney disease. Those have shown sort of a different profile, right? It's reduction in mortality, but reduction in heart failure hospitalizations, in progression of renal disease or deterioration of renal function. So they seem to be mechanistically different and maybe quite complementary.
Yeah, very much related to volume. And of course, with patients with diabetes, that spans heart failure with preserved ejection fraction, heart failure with reduced ejection fraction or moderately reduced. But yeah, that is an important distinction. And we see that coming into play in guidelines, as hopefully we can talk about a little bit more as the cardiologists or people in cardiology practices and internal medicine practices start thinking about, okay, well, what agent am I going to reach for to try and improve this patient's future risk and improve their outcomes?
So as an interventional cardiologist, I focus mostly on the patients with ischemic heart disease, although obviously the heart failure population is very relevant to heart disease specialists as well. But for the ischemic disease population, I think we have a fairly consistent story of about a 15% reduction, relative risk reduction with GLP-1 receptor agonists. So what is the current algorithm then, in terms of, it's been changing recently with the American guidelines and the European guidelines, in terms of the sequence of agents to start, first line, second line. It used to be more metformin for everyone. Is that still the case? What are you doing in your practice, in your prevention clinic?
So many patients come in on metformin that it's often background therapy, inexpensive, generally weight neutral, although the cardiovascular benefit has been suggested, but less, definitively shown, as we've seen with these two drug classes. In many cases, we're using this focus of building off metformin. Many patients not optimized. And we certainly see, as I did in clinic today, people who are coming in on older agents where I know that they don't have cardiovascular benefit, like the sulfonylureas, and their A1C might be okay, but they're achieving that A1C with an agent that doesn't have cardiovascular benefit. So we have incorporated these into our practice and are using them, trying to come up to speed on using them, involving internists in that decision making. We certainly see sometimes they will have an endocrinologist who isn't necessarily using these drugs, and that's an important point of why we as a cardiology community need to be engaged with this, because you can sometimes encounter the idea, especially in the community practices, of saying, well, it's really a cardiology drug, so I'm going to defer to you about which one of these drugs you're going to use in terms of cardiovascular benefit. But we're often following that general outline of when we think that the ASCVD risk, the risk for ischemic events, predominates, of looking for GLP-1 receptor agonists used first as an add-on therapy, whether that's with discontinuing older agents that don't have benefit, adding it on to metformin, or even now, when possible, using it as first-line intervention in someone who hasn't yet been treated. Interestingly, as we might touch upon in terms of mechanism, the GLP-1 receptor agonists can exert quite an effect on weight loss, which patients like, and among them, there are separate indications for weight loss and obesity outside of treating diabetes. And so, an obvious extrapolation from that is the patient who you're seeing who has high risk for ischemic events and is significantly overweight is saying, well, here a GLP-1 receptor agonist is going to be helpful because I'm not only going to treat their diabetes, I'm also going to be doing something about their weight. And of course, we think excess adiposity, obesity may be central to a lot of things that contribute to cardiovascular risk, including, hypertension, sleep apnea, even
inflammation,
elevated triglycerides,
the
inflammation.
And obviously that's a huge topic, hugely topical issue in cardiovascular diseases, inflammation.
Yes.
Yeah, I mean, there are multiple mechanisms by which GLP-1 receptor agonists may reduce the cardiovascular risk beyond simply the glucose reduction.
But it's a key question. I'm hoping that you're going to answer it today. Why do GLP-1 receptor agonists work in reducing cardiovascular events? What's your take?
Yeah, I think the inflammation is probably a big part of it. We're seeing more and more data as we get more potent anti-inflammatories and the data showing that sort of similar effect on reduction in cardiovascular events with inflammation reduction as there is with LDL reduction in the current era, not in the past era where there was no LDL reduction, but incremental now. Very strict targets for LDL achieve about the same thing that you can get by reducing inflammation. So I think that's a part of it. But as you point out, the effect on the consequences of overweight and obesity, and that's a topic of another one of these vodcasts later on as part of this series, is the influence of these drugs on obesity.
And as you said, that the inflammation could be part of it, but I think, if we have the thought question about, is it just going to be those with elevated inflammatory markers who benefit from these drugs? I think, it's probably a combination, and it's always been very impressive to me about how many things go in the wrong direction when someone is overweight, and how significantly so many things get better with even modest weight loss. So now with these drugs where you're having more significant weight loss, I think it's, could well be, part of the story. Yeah. It'll be exciting. We're still learning.
I think I think it's an easier treatment algorithm, so to speak, when you identify a new patient. As we not uncommonly do, patients coming in with their incident cardiac event are diagnosed as part of that evaluation with either prediabetes or diabetes. I think it's easier to frontline this class of drugs either ahead of metformin, which I think the new guidelines actually advocate, or immediately after. But there are obviously practical difficulties if they're on other drugs, right? And especially for cardiologists who are not as accustomed to managing glucose levels and preventing hypoglycemia. And so, how do you deal with that in your environment where you've seeing a lot of these patients who have already come in with these agents?
The first step is, of course, engaging and sort of saying, I need to know this. I'm going to read the guidelines. I'm going to read some summary topics. I'm going to start asking questions. I think beyond that, as it comes up when you're seeing patients, is to also recognize patients in whom it's just a no-brainer that they need better glucose control. There's not going to be an issue with hypoglycemia. You're seeing a patient, who's follow-up visit and they, you just stented them recently, or they were just in the hospital with having had an event and a PCI of saying, well, the A1C is 8, the A1C is 7.5, and let me initiate this and then collaborate with the internist about let's move on from there. Let me know what to say to the patient about the drug and why you're making that step and the benefit and what they can expect. These drugs in the trials tend to be very well tolerated. You really just have to move up the dose. There can be, they are the signal that goes from the gut to the brain about how much you've had to eat. They are the satiety signal. And so mixed into that, and part of the weight loss can be some initial nausea, but not everyone gets that. And as long as you titrate, along the way,
slowly,
it's going to be well tolerated.
And I think it's also important that the drugs, they by themselves, they're rarely associated, if ever, with hypoglycemia.
Yes, right. That's why you might say, I'm going to stay away from the patient who's got who's already on 2 or 3 agents, and I'm adding this, and their A1C is 6.4. Right. Say, well, maybe I'm going to avoid that, or a history of hypoglycemia, and that's what I was alluding to in the patients who have higher A1C levels, and it's not an issue. Yeah. You don't have to worry about that. And in ones where you have a question, is then engaging with endocrinology or their internist about, hey, let's do this. On that spectrum of engagement can be simply, as the cardiologist, saying, shouldn't they be on these drugs? But I think that sometimes, in terms of getting over this hurdle of cardiologists embracing use of these agents, is that we get so concerned about treating everyone that we're missing the ones where it would just be easy and very likely to be well tolerated and to be impactful. And then when someone's complicated, brittle, their A1C is low, there's some other issue that then you'd say, okay, well, let me get someone who does this all the time and let me learn from that case about, well, here's where one has to be careful. But they tend to be well tolerated and not cause a lot of hypoglycemia, especially if you're doing that as a first-line drug.
Yeah, no, that's actually a very good point. It's a victory if we even find a relatively small fraction of those patients who need it, get them on what they otherwise wouldn't be.
Yes.
And taking this a step at a time as we get a learning curve. So.
Yes, absolutely.
Well, Jorge, I think this has, been a very interesting discussion, particularly, regarding some of the practical aspects. But as you pointed out in the beginning, this is a very exciting time because we actually have now drugs that are like our other treatments for prevention for cardiovascular disease that make diabetes and hyperglycemia a modifiable risk factor now for the macrovascular cardiovascular events. So, it's very topical, and I think it's something that there's obviously a curve in getting comfortable with, but we all need to become part of that treatment and that application of those therapies.
Yes, I agree completely. I think sort of my top line, perspectives on this. One is you just alluded to, whereas there was a time not that long ago where we might have said, well, as a cardiologist, we don't need to be the one to diagnose diabetes because what would we do with that information? It's not going to change outcomes. Well, that's now changed. You can say, well, I'm seeing a patient with a very high fasting glucose, the day after their end STEMI. Maybe this patient has diabetes. No one's ever checked for it, getting an A1C, or patients who have very high triglycerides or patients who are overweight can all be reasons to check for it because that would lead to the initiation of therapies that can improve outcomes. And then I think the other, big perspective here is that the outcomes improved by these drugs are our endpoints. We own them. We can't stand on the sidelines and look for someone else to teach and lead and guide and treat about improving, MI, improving stroke,
Right.
improving need for coronary intervention. Those are ours. And so it's exciting to see the times change, and, we have to change with them and embrace these agents and the impact they have and how to use them and how to use them safely and appropriately.
Well, thank you all for participating in this Heartbeats from Lifelong Learning today, where we heard a lot of important points about the cardiovascular benefits of GLP-1 receptor agonists. In closing, I'd like to encourage primary care and cardiovascular care providers to consider how they can proactively advocate for and utilize these GLP-1 receptor agonists among the high-risk patients with diabetes in their practices. To get additional information and to claim credit, please visit learn.heart.org. And the views and opinions in this podcast are those of us, the speakers, and reflect synthesis of science. And the content should not be considered official policy of the American Heart Association. Thank you very much.